Somewhere to sleep. Good evening, everyone. My name is Doug Stollery, and I have the privilege of serving as Chancellor of the University of Alberta. This land has been a gathering place for centuries. The University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. On behalf of my colleagues at the University of Alberta Senate, welcome to the Chancellor's Forum. Mayor Iveson had every intention of joining us this evening to bring closing remarks, but he's under the weather tonight and he sends his regrets. Our focus this evening is on the human and social factors at the heart of the opioid crisis. We recognize that this evening's topic may be emotional for some. Should you require any assistance, we have designated supporters who are here to help you and are seated at the exit doors on the left and on the right. If you need to leave the auditorium and you don't require assistance, we'd ask that you simply give the supporters a thumbs up at the door to let them know that you don't need them to step out with you. If you've read any recent headlines, you will know that Alberta has the second highest rate of opioid deaths in Canada. These are not just statistics. We'll open this evening with 3 minutes of photographs of loved ones lost during this crisis in our communities. This presentation was created by Mums Stop the Harm, a prominent Canadian parent advocacy organization representing families who have been impacted by substance abuse. Mums Stop the Harm has generously given permission to share these photographs here at the forum. The organization is represented by Angela Welts and Lorna Thomas. Angela and Lorna, who are here with us tonight. Thank you for joining us. The photographs will be accompanied by the song We Remember, which is from the Street Requiem. It was composed by Kathleen McGuire, Andy Payne, and Jonathan Welch, who have also generously given permission for the music to be played here this evening. Premiered in Australia in 2014 and performed across the world, Street Requiem was written as a dedication to the homeless, those who have died living on the street, and those suffering from addiction.
Thank you.
Thank you all for joining us, and thanks to those of you who sent questions in advance with your registration. We've shared your questions with our moderator, Mr. Ryan Jesperson of 630 CHED. I'm deeply grateful to the Royal Alexandra Hospital Foundation for their sponsorship of this forum. Mr. Andrew Otway, President and CEO of the Foundation, is here with us this evening. Andrew, thank you for your ongoing commitment to improving health for individuals, families, and communities across our province. And thank you to our campus partners and organizers, the University of Alberta Alumni Association, the Faculty of Medicine and Dentistry, and University Relations. In addition, thank you to the Faculty of Arts Resource Center, our American Sign Language interpreters, and our volunteers on the Senate's Campus Inquiries and Initiatives Committee. I'm also deeply grateful to our panelists and to our academic partner, the School of Public Health, for their support to the forum and their leadership on this issue. I now invite you to watch two 90-second videos shared with the permission of the See Beyond, See the Lives project. See Beyond, See the Lives was created through a partnership among university researchers from the University of Alberta School of Public Health, the University of British Columbia School of Nursing, and the University of Calgary O'Brien Institute for Public Health, and the leaders of Mums Stop the Harm and Mums DU.
It's been more than 6 years since you chose to end your life, and I have struggled with the helplessness and sense of failure I felt in not being able to protect you. You were socialized as a young man and conditioned in the workplace to exhibit strength and avoid exposing any vulnerability. I too am a product of that same conditioning. How I wish I had been a better role model for you, expressing my emotions, my vulnerability, my weaknesses. For that, I'm deeply sorry. I have to think your means of coping, self-medicating, led you to experience the damaging stigma associated with the labels of addict and criminal. That stigma undoubtedly reinforced the emotional isolation and negative self-image that made it so difficult to ask for help. I would like you to know you are so much a part of who I am. I also would like you to know there was nothing we wouldn't have done to have you stay with us. Your loving father.
Hi, sweetheart. Sorry, I haven't been for such a long time, but it hurts. In January, we would be celebrating your 30th birthday. You were 25 when we found you in your apartment with a needle by your side. Danny, there's so much I've learned since that fateful day, and so much I wished I had known in time to help you. You didn't know that deadly drugs had entered the illicit market. You were one of the early victims before fentanyl made the news and before there were any health warnings. Imagine if we had a poisoned water supply and more people were dying. Would we allow for this to happen, or would we fix the problem? We did not understand how treatment should look like, the risk of relapse, and how to keep you safe. I wish I had known about harm reduction, about keeping people as healthy as possible without judgment or shame, about the medication in naloxone that can reverse an overdose. Thousands of lives have been saved, and now I carry a kit in my purse wherever I go. I do know you would be proud of me and the advocacy work I do with other affected moms and families in our group Mums Stop the Harm. Sweetheart, you're delivering your story. I'm a voice, and I get to speak your name. Take care, sweet. Love you forever and always, until I find the strength to write again. Petra?
Tonight is an opportunity to share perspectives supported both by research and the lived experience of people engaged in the work and contributing to difficult and at times heartbreaking conversations on this complex issue. I'd invite our panelists now to take their chairs up at the front. And now over to our moderator, Mr. Ryan Jesperson of 630 CHED, whose contributions to our community have been recognized by many organizations, including the YWCA and the Alberta Council of Women's Shelters. Ryan will introduce our panel and begin our conversation. Please join me in welcoming Mr. Ryan Jesperson and our panelists.
Thank you, Chancellor. Well, thank you very much, Chancellor Stollery, and thank you to all of you for being here. This is remarkable turnout, and I know that it means a lot to our panelists who are gathered here to participate in what we know will be a difficult but integral and important conversation. If we acknowledge that we are in the midst of an absolute full-blown public health crisis and take that as an agreed statement of facts of sort, it'll allow us to get into conversation immediately with great meaning, as the Chancellor mentioned, based on both evidence that we have in front of us and lived experience. It's a pleasure to welcome to our panel Dr. Catherine Dong, the Director of the Inner City Health and Wellness Program, the Addiction Recovery Community Health Team at the Royal Alexandra Hospital. Dr. Dong, an emergency physician at the Royal Alex and associate clinical professor in the Department of Emergency Medicine. She completed her fellowship at the Royal College of Physicians in Emergency Medicine, receiving a master's degree as well in population health right here at the University of Alberta. As an emergency physician, a volunteer, and a researcher in Edmonton's downtown core, she began to think about how to improve healthcare service delivery and health outcomes for patients who use substances and experience multiple social inequities. Dr. Catherine Dong, thank you for being here. Mike Sir is the Chief of Police in Abbotsford, British Columbia, as well as the Chair of the Canadian Association of Chiefs of Police Drug Advisory Committee. The Chief holds a degree in criminology from Simon Fraser University, served 26 years with the Vancouver Police Force before heading just a little bit east. He's a leader in the fight against the opioid crisis and is the chair of the Abbotsford Opioid Working Group. He's been the recipient of several commendations and awards during his storied career, including the Lieutenant Governor's Meritorious Service Award. Let's welcome Chief Sir. Chanel Tuan is an Edmonton outreach worker and a member of AWARE. That's Alberta Addicts Who Educate and Advocate Responsibility. And I'm going to ask you about that name in just a little bit, Chanel. As well as the Canadian Association of People Who Use Drugs. Her road to recovery from addiction to morphine and cocaine began in 2005 after suffering a great loss when her brother was murdered. Chanel is a frequent speaker at Health Canada events and a valued member of our panel tonight. Please extend a warm welcome. Donald McPherson is the Executive Director of the Canadian Drug Policy Coalition and one of Canada's leading figures in drug policy. He advocates drug policies based on 4 pillars: principles of public health, scientific evidence, human rights, and social inclusion. Donald is involved in drug policy work at local, national, and international levels and is a founding member of the Canadian Drug Policy Coalition. Donald McPherson. And Dr. Elaine Hishka is an assistant professor in the University of Alberta School of Public Health, as well as scientific director of the Royal Alexandra Hospital's Inner City Health and Wellness Program. Her research is focused on advancing a public health approach to substance use by evaluating novel interventions designed to reduce the health, social, and economic costs of drug and alcohol use, analyzing the social, legal, and political determinants of substance use policy and practice, and examining health inequities and service barriers faced by socially marginalized populations who are experiencing problematic drug or alcohol use. Dr. Elaine Hishka. So here's the problem that we face, to put it lightly. Over 4,000 people in Canada, more than 55,000 south of here in the United States, are dying each year. In Alberta, as mentioned by the Chancellor, we have the second highest rate of opioid deaths in Canada. 2 Albertans die every day. There's a growing consensus that current strategies are not working. Donald, you and I were speaking casually before this event officially kicked off, and you told me that this is the second opioid crisis you've seen. Take us back to the early 1990s.
Thank you, Ryan. It's hard to start after what we just saw, but it was very reminiscent of the 90s in British Columbia, where I was working in the downtown east side of Vancouver. And in British Columbia, 400 people, when we reached 400 people dying of overdoses in 1993, the chief coroner went ballistic and developed a task force and went around the province talking to everybody, literally everybody. He just could not understand what was going on in the province. There were 200 in Vancouver, 400 in British Columbia. And it was a change in the heroin supply from a supply that was weaker to one that was much stronger, and people were dying of heroin overdoses, and heroin and alcohol and heroin and other drugs. And so we went through, I hate to say it, but we went through a very similar process of what we're doing now. We're trying to come up with new ideas. We're desperately trying to figure out what's going on. Authorities were very slow to move. The chief coroner's report was shelved. It was a brilliant report, called for treating this as a health issue and moving resources from the criminal justice system to the health system. Even had a chapter on decriminalization and regulation or legalization. He was really trying to put everything out there on the table. And the report languished. It was shelved. And people kept dying right through the 90s. 1998 was another 400 people in British Columbia. And we made some progress. Numbers came down to around 150, 200 a year, which is still ridiculously high for this issue. But that was the normal. That was the new normal, 200 a year. So in 2013 and 2014, when we saw this thing beginning to happen, this onset of fentanyl in the drug supply. Can you hear me? No? No. Okay. I'll speak like this. The onset of heroin, of fentanyl in the drug supply in 2013, 14, 15, and saw the deaths beginning again. And in British Columbia, they surpassed 400, just blew by that to 1,500. First 900, 1,200, 1,500 the last couple of years. And it just breaks my heart that we had an experience in the 90s that was every bit what you just saw on the screens, and we didn't figure out how to prevent it from happening again. I'm afraid we're there again. Will we figure this out, or will we just perpetuate a very bad situation?
Chief, we're going to hear this reference several times through the evening, I'm sure, and that is the idea of reallocating resources from criminal justice to public health, criminal justice to health. Does this concept have the blessing and the endorsement of a chief of police and the chair of the Canadian Chiefs who's specifically looking at the principle of decriminalization?
Yeah, I mean, I want to be coming at this from an evidence-based perspective. So I do believe that we need to look at different ways of managing this. I believe what we've done hasn't worked, which is we've had 3,000 deaths in British Columbia in the last 2 years, so it's not working. So I am open to new ideas, but what I want to say is we have to have the systems in place. So for example, I will tell you that we've probably de facto decriminalized all drugs in the Lower Mainland or British Columbia for the most part. We do not charge people with simple possession. Yet we have some of the highest, in fact, we're the worst province for overdose deaths. That doesn't mean that I think we should charge people simple possession. I absolutely don't. But what I do believe is we have to have the right systems in place, and that is treatment, opioid-assisted treatment, prevention and education in place before we just simply decriminalize. But again, I don't want to be arresting. I believe it's a health issue. I believe police, we should be focusing on those that produce, distribute, traffic those drugs. And that's where our focus should be. But we have to have systems in place to support people in advance.
And we'll develop a robust conversation, I'm sure, over the next hour and a bit on what those systems look like. Dr. Hishka, everyone in this room, I'm sure, wants to base opinion and public policy on evidence. What is the evidence telling us from your perspective on how we got to where we are and how we should move forward?
Thank you for that question. I think it's interesting, like Donald was referencing the 90s, but we've been talking as a country about drug policy and how we approach substance use, since the Ledane Commission in the 1970s and 1980s, where even then people were discussing decriminalization or legalization. Like, these are not, frankly, new ideas. But the evidence, and the reason we've been having these discussions even from that far back, is because the evidence is very clear from a public health perspective that enforcement-led approaches or criminalizing people who use drugs not only are ineffective for deterring use, but they actually exacerbate the harm that people experience. And so obviously when you use drugs, there's risks involved, but what we know from a scientific perspective is that those risks are actually in many ways exacerbated by criminalizing people who are using drugs. So people are less likely to be open with their loved ones to discuss their use because it is a criminal activity and it's very morally stigmatized. People are less likely to talk to their healthcare providers. They may be worried about losing their children, or they may be worried about other negative ramifications for employment. And so that's really what got me interested in this area, is starting to study how, not just how ineffective policy was, but how we knew policy was ineffective, and we have the evidence, and it shows that very clearly, and yet we have been unable to act and to really take a radical new approach to this topic. And so my personal interest is on figuring out ways that we can move the dial, because this is not, from a public health perspective, this is not new information, and yet we're seeing the historically unprecedented negative consequences. And we really need the will and the public support, I think, to have brave
I want to encourage our panelists to please feel free to jump in and contribute to the conversation by adding your own perspectives on what you're hearing. Chanel, how could we not be moved by those two real parent testimonials that Chancellor showed before we began our conversation? There was a reference throughout to the stigma, and we understand that stigma can be a very significant barrier that stands in the way of people reaching out, as well as standing in the way of making progress from a societal perspective. How do we end the stigma against those who use substances such as opioids, and how do we meet their needs?
Really, the videos that we were shown just now were absolutely incredible and amazingly moving. When we were hearing the numbers referenced by Donald, by Elaine, the amount of Canadians, the information on the screen previous to, the event starting here tonight, when we see 11 Canadians a day dying, now attach a name and a face and a story to each one of those individuals, and really, this is the crisis that we're dealing with. We need community champions spearheading pretty much system overhauls. Being an outreach worker here in Edmonton, the inner city, and coming into contact with quite literally thousands of people like myself, people who use drugs. I've had many interactions with the healthcare and social services and justice systems with folks, and have come to learn, and from my point of view, I guess it's anecdotal, that we do need a variety of system overhauls. The stigma and the discrimination that continue to exacerbate this crisis that we're experiencing. We call it an opiate crisis, but I think really what it is, it's a fentanyl poisoning crisis. I've actually, in talking in discussions with one of my mentors, you all might know Ms. Marlis Taylor, we were talking about grief and loss and how that kind of really affects us all. And we were talking about kind of the AIDS crisis and the HIV and what happened in the 80s and 90s. And at one point, we were there in that instance. We had time. We knew maybe a loved one would fall ill, and there would be time to kind of not get used to the fact that that person would soon not be with us. But when it comes to this fentanyl poisoning crisis, your loved ones are there one day and the very next day they are not. So I think the stigma and discrimination that is attached to being a person who uses drugs and a person who uses opiates is going to take a lot of work to keep at bay. Really, we need community champions like the panelists up here, like Dr. Elaine Hishka, like Dr. Dong, like Police Chief Sarah. I never thought I would say that in my life. Finally had a police officer. I almost started with a bad joke with Mr. Jesperson. I said, oh great, I'm the only one up here with a criminal record probably, and they sit me at the table with the cop. But realistically, we do need some major system overhauls, and I think that can only be spearheaded by community champions and people in the community, people who are working at amazing organizations like, Mom Stop the Harm and HIV Edmonton. And I'm sorry, I'm going to be a little bit self-serving for a second, and places like Streetworks, where Streetworks is celebrating its 30th anniversary this year and serving the city of Edmonton, being Edmonton's only harm reduction program. And one of my, not only my employer, I'm not trying to get brownie points here, but one of my mentors who has truly worked in the city for decades, serving people who use drugs in a compassionate, kind, and understanding manner that, this could be anybody. This could be somebody's son or daughter or brother and sister, mother or father. The saying somebody's somebody definitely rings true, I think, for all of us when we think that, these are only 2 videos that we saw. Now, I think if it would be a different story for politicians if we were able to, attach everyone's name and story and play them on a reel in the House of Commons. I mean, I'm not sure where it has to land, but the policy and decision makers in this country have to step up, and there's a time to remember and there's a time to act. And I mean, in the 90s, I was a child, and I have children now, and I imagine that many of you do, but we, as parents, how can you not watch these videos of loss of other parents and not feel the weight of the stigma and discrimination that has been placed on them? So, yeah.
You almost rattle off statistics in cold fashion, don't you? When you talk about a story like this, you say 4,000 Canadians die every year, you say 2 Albertans die every day. You rattle off these numbers trying to paint a picture. For me, one of the more striking memories that I've had in the context of this conversation was on Christmas Day, just a short time ago, just several months ago, when a friend of mine, a big strapping firefighter, had his voice crack throughout the entire conversation talking to me about their call where they attended a home. It doesn't matter, but it was a home in the suburbs where a mom went in to wake up her son in his early 20s for their traditional family Christmas breakfast and found him overdosed and dead in the room. And that was one of 2, per the statistics, one of 2 Albertans that would die that day. But for that family and the ripple effect felt from that death, there were thousands of lives that will forever be changed. Dr. Dong, based on your perspective, gleaned from working as a physician in the ER, in the downtown core, if we want to broaden our focus or expand the conversation beyond what we typically talk about in the context of treatment and harm reduction, if we want to go beyond criminalization and prohibition, based on your professional lived experience, where does that conversation need to begin?
Oh, great question. I think we need to start with making sure people have access to all forms of treatment. First of all, that have evidence behind them. We have a long way to go in achieving that. You should be able to walk into any hospital, family doctor, health clinic, emergency room, and immediately have access to life-saving treatment. This is a life-threatening medical condition. We would not let you walk out the door with a heart attack and say, next week we'll see you. We treat that immediately. So we need to start with that, I think. Immediate access to life-saving treatment. Beyond that, I think when we are able to offer that to everybody, we need to look at other options, like safe supply, decriminalization. Those are things that need to be on the table, and we need to move quickly. We have not moved quickly enough to save the lives we needed to save, and it is heartbreaking.
Donald, let's pick that up right there. Safe supply. what would a model look like that you think might work in Canada?
Well, I guess, am I on? Is my microphone on? Oh, the mic's fine. It's just weird. I can't. Anyways, I guess I'm on. Now I'm really on. Sorry. I guess there's a tension with what both Mike said and what Catherine said, in the sense that we have a public health emergency. Politicians are leery of calling it that. In British Columbia, emergency has been declared. We're coming along to the 3rd anniversary of a public health emergency declared by the Provincial Health Officer of British Columbia. Having said that, we've behaved sort of like you've behaved here in Alberta. You've done some good things. You've pulled together a commission. You've expanded treatment. You've opened supervised consumption services. In British Columbia, we have some other kinds of services. But to me, there's a tension between building a system of treatment, reorienting our services to where they really need to be, spending the years lobbying and getting the funds that are necessary to do that, and responding in an emergency fashion. If I were running things and a public health emergency was declared, I would immediately bring my best and brightest minds together, including many people with lived experience, and say, my God, the well has been poisoned. How are we going to get safer substances to people in Alberta, because 2 people are dying every night? There's a bloody salmonella epidemic going on across the country, and it's possibly taken 2 lives. There's 60 or 70 people who've gotten it, and the public health community is all in a big flap. We have a bloody crisis that is killing people at these rates that we're talking about, and it's a Chanel's absolutely right. It's not an overdose crisis, it's a poisoning crisis. A community of people in Canada who happen to use substances can only buy them on the illegal market, and the well has been poisoned. So they are forced to go to that market and take their chances, or stop like that. And we all know that's not the way it works when you're dealing with addiction. So it's a very difficult. We can't wait till we have all the services in place before we do something radical like a safe supply or regulate these substances. We have to act now, and I think the safe supply discussion it's a precursor to the regulation discussion and a legalization discussion, but it's really a harm reduction, an attempt to give people a chance to live another day, because many of these people are very experienced drug users who will know how to use a substance of a known potency. So I think safe supply definitely is something we haven't figured out. There are small pilot programs going on in Vancouver, a couple of them, where people are able to access diluted pills, injectable hydromorphone. I think that's happening here too, to some extent. And this is outside of a treatment context, but it's an attempt to give people who are really between a rock and a hard place an alternative where they're not going to die from some unknown poison in their substance tonight. And someone's at risk tonight on the streets of Edmonton, Calgary, Vancouver, Prince George, Elora, Ontario. The well has been poisoned, and we need to take the safe supply serious. It's not a simple fix, it's complicated, but why aren't we having our best and brightest minds figure out how to do it?
I'd like to give our other panelists an opportunity to respond to what Donald just said in the context of safe supply.
Yeah, maybe I can go ahead.
No, go ahead, you can.
So I guess just from a policing perspective, what I can tell you is I wish I can sit here today and tell everyone that we can control or enforce our way with the supply. History has proven over and over again that unfortunately we're not arresting our way out of this. Now it doesn't mean that we're going to stop. We're going to stop hitting organized crime who are bringing this poison into our streets, but what we need to focus on, in my opinion, is the demand. Because the supply has been very, very challenging, and fentanyl is absolutely the perfect drug. It's easy to source, easy to import, it's highly lucrative. So it will always be a challenge for us. So I agree with Donald, we need to look at the demand. And I'm a very strong advocate for programs that opioid-assisted or agonist therapy. What I always say is a drug dealer, their goal is to make you take more and more drugs. Hopefully a doctor or somebody who is a clinician could help somebody or assist somebody is trying to moderate it or assist somebody with a supply of drugs. So the elephant in the room is somewhat is that, you know, what we're seeing in Vancouver is people, or my city as well, is people are going on the streets, they're buying a poison, they're going to a supervised consumption site, they're overdosing, they go back on the street, they buy a poison, they go back in, they overdose, we help them. That's not the answer. So I agree with Donald. I would like to look at a safe supply, but I also agree with Donald, it's not an easy answer. How do we distribute it? How do we give it to people who are not, for lack of a better term, entrenched drug users, somebody who may be, as we call, the weekend warriors? How do we find that balance of supporting people? So the other thing I would just want to throw in is I do not think we've invested enough in prevention and education. I'm not naive in thinking that's going to solve everything, but we truly have not invested enough in this to help educate our youth and others that this is a very dangerous path and it is a health crisis, but there is help there for you.
Dr. Hishka?
Well, Chief Sir and I always agree on that point, that enforcement is not going to necessarily reverse the trend, specifically with fentanyl. If you think about how complicated things are in terms of illegal drug selling these days, like with the internet, with so many different ways to bring in this very toxic substance, nobody in our field expects that it's going away anytime soon. And so as long as it's the #1 drug and it's more convenient than treatment, your dealer will drive to your door, they'll give you what you want, they won't ask you any questions, they won't stigmatize you or judge you. People are going to continue to choose that option as opposed to medical treatments, which we currently have, and some are very excellent, but they tend to be harder for people to access. There tends to be more rules, and there tends to be a lot of restrictions on what people can do while they're on them. And until we find a balance where we're trusting people to have access to pharmaceutical drugs, where they're not having to drive to the pharmacy every day or do things that are just very inconvenient for them to live their lives, I think it's very challenging. So I agree with the idea of a safe supply, and I don't think we're too far apart. I think we need to find low threshold ways to provide people to medical care, or connect them to medical care, and also to safer drugs. And I agree on the prevention piece. Obviously, I'm a public health person, but effective prevention will take strong and significant investment now, and the return on that investment we will not see for a decade or two. The way that you prevent substance use, this is the same way that you prevent bullying, or the same way you prevent violence or other types of risk behaviors, is to invest in communities, to strengthen school environments so that youth feel included and connected, and to strengthen families, reduce child poverty, to connect parents that are struggling with support so that their families can thrive. All those are critical things that we should absolutely be doing as a society, and I 100% support investing in those things, but we will not see the return on that investment for many years, and in the interim we are losing people in the prime of their lives, in their 30s, who should be getting married, who should be making career achievements, and who should be having children, and their families are losing those people. So I think we do have to act urgently and treat this like the emergency it is, while keeping an eye on prevention. And the reality is we need to do all these things at once, and I don't think there is a priority. I think it's all now, and we are not seeing that.
Doctor, you're nodding in agreement. If I can sort of further this conversation, but in the same context, if we want to talk about education and we want to talk about access to services and programs, I suppose, if possible, it would be beneficial to be able to identify the demographic most impacted by this crisis. What do we know about it, and where would education begin? I mean, I'm off the top of my head, just as a layperson, thinking about educating physicians, thinking about educating potential drug users, thinking about current drug users, healthcare professionals, decision makers at all levels of government, members of the media that report on this and either perpetuate certain language that's not beneficial. You get my point. I mean, where do
It's everybody.
It's everybody.
It's
Where do
everybody.
we begin? What do we know about the demographic?
The demographic of people affected, or
Yes.
just, well, it's young people, young men and women, mostly men, that are dying. I agree with Elaine 100%. We need to start way before people ever get their first opioid. We need to teach children and put them in situations where they can role play and learn how to get themselves out of those situations. Education is not enough. Marketing campaigns are not enough. We need to actually have kids practice the skills that they need to get themselves out of difficult situations. We absolutely need to train more physicians. I learned very little about substance use disorders in my emergency medicine training. I know a whole lot more now, and I wish I knew it earlier, honestly. But we need to build training programs for physicians and nurses and social workers. We need to educate the media, absolutely. We need to educate government officials and decision makers, law enforcement. We all need to learn together and work together. Most importantly, I think we need to learn from our community. You know, Chanel coordinates our community advisory group for us, which it is our community and people who use substances that are going to tell us, honestly, how we can do better and how we can improve. So we need to be learning from our community and listening very, very closely to our community to figure out what our next steps need to be. So I don't know if you want to expand on that.
Yeah, so to expand on what Dr. Dong has just said, the community advisory group that is composed primarily of members of AWARE, Alberta Addicts Who Educate and Advocate Responsibly, has been providing input and feedback into the programming that has been happening out of the ARCH team at the Royal Alexandra Hospital. The ARCH program is the Addiction Recovery and Community Health Program in our province's busiest hospital. What they're doing is absolutely amazing. If we could have an ARCH team in every emergency department across this country, we would be far better off for it. Instead of kind of the revolving door that was happening, saying somebody who uses drugs as a drug-seeking person coming into the emergency room looking for the next fix, let me tell you, as somebody who has spent many hours in the emergency room, that is not the first place anybody who uses drugs would go to sit and wait 6 to 8 hours to see somebody to obtain a substance. What they're doing now is looking at people more holistically, and in turn, people are feeling like they're being extended some humanity and some compassion, that they're actually is somebody who gives a shit, sorry for lack of a better term. These doctors are absolutely providing people with an opportunity to have a safe and welcoming and compassionate place where where we now have the first supervised injection service implemented in hospital. That is an absolutely amazing feat in itself, to think that, that isn't happening anywhere else. But here in our city, we have amazing community champions that are spearheading things like this. And how do we get this implemented in other parts of the country where it's also so desperately needed?
Ryan, I was just going to add that I agree. This is an emergency, and we need to act fast, and we need to stop the damage that we're seeing now. I'm very proud of a program I want to bring up because it speaks to what you're saying, Chanel. In Abbotsford, we started a project called Project Angel, and what we have, we received $100,000 from the province. We've been now extended to the end of 2020, and what it does is we've hired a half-time coordinator and 7 people lived experience, because I was tired of our police officers or first responders going to someone that had overdosed, giving them the naloxone and then leaving only to come back the next day and the next day, or take them to the hospital, them coming out and then again. So what we can do now is our police officers can give a person a card and then immediately call a person with lived experience, an angel, like a victim service program, who will come out on the street and meet that person. And we have access now, working with our health authority, to get people quicker access into a treatment bed, to see a doctor for agonist therapy, or just to provide peer support until that person is ready. And for me, I really believe in this because I think what we have been doing isn't enough. And to have, people need that access right now. So Project Angel is 7 months in. We've already had, and it's, sorry, one other thing I should add is, I also believe when we see people who are doing survival crime, so if we have someone that's broken into 10 cars to support a drug addiction, to have an angel go to the jail and meet with that person and provide guidance and support for that person and get them into, again, a pathway that works for that person. So we've only been 7 months into this program, and we have already helped over 100 people on the streets and provided many of them with quick access. So these are the types of things we need to do to stop the crisis now. But I agree, we need to think differently. I am a believer that if we keep doing the same thing over and over again, we're not going to make a difference. So I am open to a safe supply. I am open to looking at different models. I just want to make sure, because I have seen some of the things we've done where we've kind of jumped, and I'm guilty of them, where we've had unintended consequences. So, making sure, but we can't wait too long, and I'm also willing to try different things, but just to be alive to some of the complex issues that come with this.
Dr. Hishka, you and I have spoken several times about different models of supervised injection services, and I think it'd probably be of value right now if you could sort of remind us of what we've seen open in Edmonton over the last approximate year or so, and what we know to this point about how those services are being rolled out. Specifically, I'd like to ask you about the opportunity, based on Chief's comments, to build relationships with frontline healthcare workers and people who use drugs.
Sure, so I'll give you a bit of background and then I'll turn it over to Chanel, because I think Chanel can speak a lot better about the opportunity to build relationships than I can, as she's a frontline service provider. But essentially, Edmonton has 4 supervised consumption services. They're 3 in the downtown core, and I'm very pleased to see a number of the advocates and the service providers and operators in the audience tonight. They have seen like over 40,000 now visits, I believe, the 3 ones in the community, and they've reversed over 2,000 overdose, or it's like, or sorry, not in Edmonton, provincially there's been over 2,000 overdoses reversed, and essentially they're embedded into existing community facilities where people who use drugs were already going for care, and they are basically an add-on to a spectrum of services that are available there. So people go, they connect with the healthcare provider, they are able to inject under medical supervision. If they overdose, they receive care immediately. And they also have really important opportunities to connect to a variety of different supports, like treatment, like counseling, like harm reduction education. And what we're seeing is the police have reported that in the areas surrounding the supervised consumption services, crime has been stable or declined. And also the city is reporting that they've seen a significant reduction in needle debris around the facilities. So I think they've been a really important addition to the services that are available. But at the end of the day, as Chief Sir pointed out, like, people are still taking toxic illegal drugs to these services and potentially overdosing frequently there, and the service providers are not able to offer them safer substances, even though those drugs are readily available in Canada, and would be an important step towards stabilizing people so that they can potentially start taking a known substance at a known quantity and start having conversations about where they're at with that, and potentially move down the path towards recovery. I think this is a spectrum, and we need to engage people in care first and foremost, and that's one really strong strategy I think we should be trialing in this province right now.
Chanel, would you shine some light for us on how these relationships are formed, and even if you would, anecdotally, respecting, of course, confidentiality, maybe provide an example of maybe a good news story?
Right. So for a long time, people were coming in and they were able to access all the supplies that they needed to be able to inject safely. So things like sterile syringes, alcohol swabs, sterile water, individual cooking spoons, all supplies so that people did not have to share and risk things like transmission of Hep C or HIV. Now we're able to provide people with a safe place to come and be able to connect with other peer support workers, nurses, social workers, who then have an in to, if they so choose, drug tapering strategies, healthcare services, social services. In reality, though, what has just been said here is that we have these great, clean, sterile injection booths, but at the same time, people are coming in and they're injecting poison. The safe supply is something that can be implemented inside of supervised injection services. I know we've seen, in Vancouver and in pilot projects across the country, prescription heroin programs, where previously, we've seen, 100 of the, deemed most hardcore drug users from the streets actually be able to come in and connect with these healthcare and social services and be able to do things like participate in life and have an employment and not having to worry about, am I going to have to access an illicit tainted market and be poisoned? Because as Donald has referred to it in the past, it's really a game of Russian roulette right now. And it's absolutely terrifying to think that we have these strategies and these brilliant minds with all these great ideas, and we have not yet implemented any of them. I think really that's maybe the public health emergency. We need to, like I said, right, there's a time to remember and the time to act, and the time to act was obviously back in the 1990s when we first we're going through this opiate crisis. And I think too, we also have to think of, so simultaneously, we are also having a methamphetamine crisis. But, you know, when people are able to come into contact with healthcare and social services and have provided to them, you know, a plethora of services, this is where the connections and the relationships are being built. And nothing is being forced upon people. The relationships that are built are genuine. Oftentimes people look at harm reduction workers as people who are enabling people who use drugs. But if we're talking about enabling people, we're enabling them to take control of their health care, take control of immediately what's happening to them. I think this is a Canadian tragedy at best right now.
Doctor?
We certainly can integrate treatment into supervised consumption service. So that's what we do with the Royal Alex. So right now we have patients that come and they bring fentanyl, but what we do is offer them either buprenorphine, methadone, slow-release oral morphine, and now injectable hydromorphone. So in our supervised consumption service, which is for inpatients only, about 50% of our visits now are for injectable opiate agonist treatment. So patients that come to hospital and continue to use fentanyl that have been unsuccessful on other treatment options, we prescribe them hydromorphone, which they come to administer. So 50% of the people of the visits that were for illicit opiate use, we've transitioned onto prescription opioids. So we can do this very, very successfully and engage people into care. I actually consider that treatment. We have well-documented evidence for prescription heroin, prescription hydromorphone. That is treatment. People come at set times, 3 times a day. They engage with a whole team. For me, that's different than safe supply. For me, safe supply is giving people opiates to use when they feel like they need to use them in a supervised or unsupervised setting. So I just want to be clear about that distinction.
Right. So you can do it, but you're not doing it.
Safe supply or?
Assisted treatment.
We are doing it. We are
Okay.
doing it.
With
Yeah,
hydromorphone.
hydromorphone, not heroin yet in this
Okay.
province, but
Right.
hydromorphone we are doing. So 50% of the visits to our SCS are for injectable opiate agonist treatment now. So prescribed, safe supply.
Right.
That's
And
treatment.
There are other clinics in Alberta that will be offering or are currently offering that service, but the reality is that's a very highly structured service, and it does work for many people, but it often doesn't work for other people, particularly people who are still employed, have family responsibilities, are needing to be in certain places certain days. It can be very difficult to go to the hospital 3 times a day to get your supervised dose. And so what we're talking about is taking the same principles of substituting toxic drugs, you know, for known quantities of pharmaceutical grade drugs, but in a way that is more flexible for people that have those responsibilities. The reality is, like, obviously nobody, you know, ideally we wouldn't have everyone would just access treatment and then they would stabilize and then we wouldn't have a drug problem. But that's not how it works. And so we know that most deaths in the province are occurring behind closed doors at home, in people's bedrooms or in their basements or wherever. And until we connect that population of people with an option that works for them, that is as convenient as a drug dealer, we won't get ahead of this crisis. And so as public health leaders, it's a difficult conversation, and we haven't been down this road, but it's a conversation we need to have because that is really the key to bringing down the death rate, and it's been something we have not been able to do yet.
How is this approach playing within the medical community?
Good question. It's been interesting for sure. We have certainly had to push the medical system to respond, even within my own hospital, to a degree that I feel matches the evidence base. You know, within medical school and residency, like I mentioned before, we haven't received a lot of training in this area. So there certainly are physicians that are skeptical of this approach. There was a lot of skepticism within my medical colleagues at the Royal Alex when we were talking about opening a supervised consumption service there. We had extremely strong medical and operations leadership that allowed us to do this, and now our hospital could never, ever go back, because it has been just practice changing for us. It is so much safer for our patients and for our staff. But it does require you to push hard against the system to get this type of change.
Donald, you've obviously done a lot of work in international drug policy and have, I suppose, been a lifelong student to a certain degree. Have you been able to nail down a couple of jurisdictions? Are there one or two that immediately come to mind where they've done something that showed some some intestinal fortitude. They've done something that was maybe a tough sell publicly speaking, but that is paying off in spades from an evidence perspective?
Absolutely. I think the sort of pioneers in stitching together all of the stuff that Catherine's talking about were the Swiss, Germans, Dutch, in the 90s, in the 80s and 90s. Like the first supervised consumption service opened in Bern, Switzerland in 1986. So this is not a new intervention. This is a very old intervention. It's just, and so they were able to stitch together the harm reduction and treatment modalities, including heroin-assisted treatment, including supervised consumption services, quite early on in the 90s. And they don't have a fentanyl problem, so they haven't had to deal with what we're dealing with now, which is a big question mark over what they would do. And I ask them, whenever I run into those folks, I say, well, what would you do? And they really do scratch their head. They have to start thinking again. So it's possible. I think the sense I get from the European experience is that there's an acknowledgement, one, that people will always, a certain segment of their society will always use a range of substances. A very small percentage of the society will become really problematic users or really harm themselves with substances, and investing a significant amount in that population is worth it because it helps the whole community, it helps people. So the investments are much stronger in terms of housing, ancillary services, certainly drug treatment, harm reduction, and services for special populations, refugees, sex workers, really piecing together a fabric that acknowledges that all people aren't the same, one size doesn't fit all, those sorts of things. And that took them some time, but there was strong political will from the president of Switzerland on down. I think the Germans were probably the next country that innovated in the same way. And their enforcement people were very much like what Mike is saying, we can't arrest our way out of this, we need a comprehensive sort of approach. And I think that's what you're hearing, this tension between a comprehensive, building a comprehensive approach, which we absolutely need to do, including the longer term prevention stuff, and the need to act tonight. And so that manifests itself in certain, I think there's been a lack of mobilization by institutional leaders, including universities, health authorities, business associations, and government in trying to tackle the urgent part of this. We've lapsed to expanding what we know and trying and innovating in terms of harm reduction and treatment. And so I guess I have to sort of say it. I mean, all of this is good, but the elephant in the room is an absolutely failed public policy. Our policy of drug prohibition was designed in the early part of the 19th century, imbued with colonial values and a very punitive framework. That's the same policy we have today with a few minor tweaks, really. It's a very punitive, stigmatizing policy, and it grows out of sort of white supremacist movements in like Canada as a white society in the early part of the last century. So it really needs to be overhauled. It needs to be changed. And all of this stuff will be easier. All of the stuff that Elaine and Catherine are talking about, and Mike and Chanel and me, would be way easier if we didn't have this monolithic, punitive, bankrupt drug policy sort of sitting over our heads, making it so hard to open a supervised consumption service, making it so hard to implement a heroin prescription. The services become stigmatized because the people are stigmatized. So that comes from our policy. And these services are actually trying to reduce the harms of the policy as much as they're trying to reduce the harms of substances. The drugs are toxic because of the policies. So we have to continue on those tracks, I'm afraid, and that tension is not easy to live with because it takes time to build a comprehensive system of harm reduction, treatment, prevention.
Yeah, I just want to, I was going to.
Yeah, sorry, what just really struck me with what Donald said there was that, you know, I've heard it somewhere along the way that, you know, someone say, I do not have a drug problem, I have a drug policy problem. And I think that's pretty much where I'm at, and I'll be repeating that probably for the rest of my life, that I do not have a drug problem, I have a drug policy problem. Yeah.
Yeah, and I was going to add, like, with regard to the 1905 and the drug laws, Canada's drug laws, like, everyone assumes that our drug laws are based on science and evidence of what we know about how different substances are harmful towards the body. But we know that alcohol actually is one of the most dangerous and most toxic substances, and yet we have a, thriving commercial market for alcohol, where alcohol is not only encouraged but celebrated. And so we don't regulate alcohol enough, and we see as a result very significant harms as a society from alcohol, but it's entirely legal and promoted. Opioids are actually, on the face of it, if you have a known quantity and you know the dosage, far less dangerous than alcohol in terms of toxicity. Absolutely, you can die from opioids, but generally speaking, the harms are lower. They're completely unregulated and illegal. So we let the illegal market bring in extremely toxic products. Just as under alcohol prohibition, we used to see people dying or going blind from toxic moonshine. We have that situation now with opioids, and we're leaving it up to criminal gangs and to organized crime to control that supply, and they're making unprecedented profits off it. So it is time to have a conversation about actually applying a scientific lens to our drug laws, and to frankly, in my opinion, regulate alcohol and cannabis a bit more strictly, because those are very commercial models of regulation, and to look at how we can move opioids under a legal framework that recognizes they're harmful, that is oriented around demand reduction, not commercial profits or promoting use, but still takes people out of the illegal market and takes profits out of the pockets of criminals, and treats everyone in a much more humane and sane way.
We had robust public conversations and debates about cannabis, didn't we, for the last 2 years? I mean, for that matter, since the federal campaign kicked off in the summer of 2015, when our now Prime Minister Justin Trudeau vowed that he would ensure that cannabis was decriminalized, and then he said legalized in Canada. Dr. Hishke, you were the first to use the word cannabis on the panel, and we've been going for 45 minutes.
And what were the taglines they used? The Minister of Public Safety in Canada, we're legalizing cannabis, we want to regulate and control it, we want to protect our young people, we want to protect consumers, and we want to take money away from organized criminals. It's all the same logic for all the other drugs.
What I was going to ask, so why has it, based on my naivety perhaps, I mean, here's the panel of experts, but why has cannabis been absent in our conversation for the first 45 minutes? I mean, it sounds to me, you made the point I was hoping to make, which is all of the bullet points appear to be right on par.
I think in part it's difficult to have a conversation around cannabis because cannabis is really a commercial model, especially in Alberta. Like, we are projected to have, eventually hundreds of cannabis outlets selling cannabis, and there's a lot of co-ownership with liquor, like liquor companies have become very involved in the commercial sector, and there's craft cannabis, and cannabis is seen as a business opportunity, and I don't think that that is an appropriate legal model for opioids. And so when we talk about taking opioids out of prohibitionary context, we're not talking about that model. We're talking about identifying people that are already struggling to start, that can easily be identified, like Chief Sir said. They come in contact with the criminal justice system frequently. They show up in the ED frequently. Their parents know they're struggling and are looking for solutions. Finding those people and offering something that works for them in the moment, that connects them to healthcare, to supports, and frankly saves their lives, because if they have a known dose and a known potency and a certain quality, they're far less likely to die. For years, we've had a problem with diverted pharmaceuticals. Our death rates were a fraction of what they are now with toxic fentanyl. And so it's basically connecting them as a first step, and then offering everything else that we do have available as a second step. Because I think once people are able to stabilize, then they can start thinking about what's next. And I think colloquially, and I'm not sure if Chanel could speak to this, but once people do connect to these treatments or get on injectables or get on methadone or Suboxone, they have the space to think about what's next. And this is the same logic, but applied to pharmaceutical grade drugs that takes them out of the legal market to start with.
I think 45 minutes into the conversation, the reason cannabis probably hasn't come up is because it's not cannabis in our country that's killing people.
The only thing I just think it's early days, but cannabis is much different than when we're talking opioids. I mean, opioids is highly addictive. I mean, it is a very dangerous drug, and so to kind of compare those models, I think, is something that I'm not supportive of and a bit of a dangerous model. I won't apologize either. I do believe, and just like with cannabis, that we always have to go very aggressively after those that are selling the illicit product, and that has to be our model. But I am very supportive of, finding a way to, as you're saying, Elaine, to get, safer supply into people who are misusing it. But I'm also trying to get my head wrapped around, this is where a panel of experts, how do I help those people who may not be long-term users, but are the person that is a construction worker, perhaps, which we're seeing a lot of those who are going out and using it, when they come home from work or on a weekend. How do I supply that person? And I also agree, it has to be a model where it's not just going to a supervised consumption site, because that doesn't fit everybody. So again, I haven't got the answer, but what I do know is the drugs that people are getting on the street will kill somebody. And the harm reduction strategies we have are buying people time, as Don said, but one day they're going to run out of their luck. It's just, and I've seen far too many people who have just taken that one dose and that was it. And so I want to find a way to get that supply to a person so they don't feel that they have to go to supervised, or they have that spontaneous moment that they want to use and they have an ability to get a supply that's safe. And we're still working on it. We're looking at different models. But one thing that I think is unique is that Canada is a very diverse and unique country in comparison to a lot of the European countries that are much smaller and easier to manage some of those systems. So I think we need a made in Canada model. And sometimes I even think more provincially, because British Columbia is much different than than some of our other provinces, Ontario even, and Saskatchewan and Manitoba. So it is complex, but I also get the fact that we don't have a lot of time to continue just to keep talking.
I think too, if we look at the evidence that we have available, which is not necessarily available across the country, but in BC and Alberta more recently, we do know that a very large proportion, frankly, the majority of people that are dying have identified to health services prior with problems. So I agree that that population of people that are like the weekend warrior or are potentially using more, I don't like the term recreationally, but that's, the colloquialism, that's not necessarily a solution for that population, but if we want to cut the death rate, moving forward this way will make an impact, because so many people, when you talk to their loved ones, they were struggling with drugs. They were identified in the system as having an addiction, or as, having chronic pain or something that would have flagged. So I think, we do need to move forward to that highly vulnerable population of people with substance disorders, even if we don't have all the answers for all of the subpopulations.
Yeah, I don't believe we can miss any single opportunity when someone presents to a healthcare service. That might be the last time that we see them, the last opportunity that we have to intervene, whether that's an emerge or family practice or health clinic, supervised consumption service. We cannot miss those opportunities. That may be the last chance that we have. It is too toxic and too deadly to wait, even the next day. We've learned this the hard way, unfortunately, with our clinic. When we used to offer next day appointments, and now we see people right in emerge because the next day was too long to wait for many of our patients.
And I totally agree with that. I think you and I were talking earlier that unfortunately we just don't have enough systems in place. We don't have enough doctors or nurse practitioners or others who can help and assist. And that's one of the challenges we have with the Project Angel is having that immediate access. Because I absolutely agree that if we have that gap, that we're going to miss those opportunities. So that is really a place that I'm advocating that we need to invest much heavier in, is having those resources available immediately for us to access.
How is the communication between law enforcement and frontline emergency medical care?
I have to say the Edmonton Police Service has been exceptional to work with. Both Elaine and I spent 5 years in Chanel working on supervised consumption service. We have an outstanding relationship with Edmonton Police, so it's been fantastic.
But the communication channels are open in the sense that relevant information, I would imagine there are issues around confidentiality and et cetera, but relevant information is shared between, for example, with law enforcement that may be beneficial for an ER doc that's treating a patient. You're talking about this critical interaction, or you use the word intervention. or an opportunity to intervene. At what point does communication with frontline police officers or even, on the ambulance, on the fire truck play into it?
Yeah, I think the communication is excellent, honestly, and certainly we have a very strong relationship with our community partners, and we feed information back and forth when we see something worrying on our end. That goes right back to the community and vice versa. So those relationships and that line of communication is really, really important.
Donald, this conversation has been moving quickly, and I'm grateful for it. We're covering a lot of ground. Is everyone taking something from this to this point? I mean, this is remarkable. And I want to thank all of you, by the way. These notes in front of me are all the questions that were submitted by the people in this room, and some really intuitive ones and some lines I'd like to get into. But you touched on something in passing, and we moved on, and I wanted to circle back. You said in Europe they don't have a fentanyl crisis. Why not?
Well, that's the name of the game. We have no idea why not, because sophisticated transnational organized criminal organizations make those decisions. I was reading a book on the plane today over here and looking at the heroin drought in Australia. The police were trying to take credit for the heroin drought in Australia. Well, no one really knows why heroin stopped going to Australia, but it might have been around the time it started coming to Canada. So there are decisions made in the towers where the CEOs of the transnational organizations that move substances around the world, we don't have no control over that. So part of me, and we're trying to, that's why I'm sort of feel like I'm the something in the room, not the elephant in the room, but we're trying to fix this system without acknowledging we don't know the answer to that question. We don't know why drugs are coming and going. Why is methamphetamine the biggest deal in Manitoba?
And Saskatchewan,
In Saskatchewan, methamphetamine. Well, that's another group of organized people moving another substance around. What happened in Australia after heroin left? Methamphetamine moved in. Talk to the Australians about ice, methamphetamine. So it's like we're a society that regulates. We probably regulated the height of this table. We've regulated the size of this room. Is the fire marshal here? Maybe there's a couple too many people in it. We regulate tons of drugs that are really harmful. But these 7 over here, you guys can have these 7. Build a global transnational industry worth $400 billion with these 7 drugs: heroin, cocaine, methamphetamines, the psychedelics, and a few others, and then a whole bunch of ones with funny names you can get on the dark web. But why did we do that? Why did we choose to do that, and why do we continue to think that we can do prohibition better? Why don't we just bring those into the fold? Of course we're not going to sell heroin to 7-Eleven. Heroin's going to be in clinics. Cocaine, stimulants, they're a problem. But do you want your people who we know are going to use stimulants to be getting it from a clinician or from the Hells Angels?
But actually, what would it look like? Like if a 20-year-old kid that's just, their parents have dropped them off at the University of Alberta, and this is their first time away from home, and they've heard that if they snort a couple, if they get into cocaine maybe a little bit, it might help them stay up, or they can focus, or maybe whatever the case is, and they're open to it, and they're not scared off by what they're hearing, and what would the model actually look like?
We'd have to figure that out, but it might be starting with, okay, there's going to be a bunch of kids coming to university this fall, and some of them are going to want a stimulant. They use Adderall right now. And so how are we going to make that use as safe as possible? Because we know there's fentanyl in the cocaine downtown. So it's a tough decision to make, but it's do we want to surround our children, our youth, our citizens with safety? We might have to allow them, they're using Adderall, they're getting Adderall from their buddies anyway. So young people aren't stupid, but we can surround as much use as possible with safer use, safety, education, harm reduction. Acknowledge it. We do it with sexual health. So just pretending, crossing your fingers as a university and hoping, oh my God, I hope kids don't come into our university and die of a fentanyl overdose this year. We know they're going to use substances. That's the key question. How do we do that? And I guess all I'm saying is that we don't do it now. We have very limited resources in terms of making that situation safer.
I would agree with, I mean, Elaine, I agree with you in the sense that, you know, if we invest in prevention and education, that's a 10-year project, and I'm told.
Minimum,
But
yeah.
minimum, and I'm not naive to that, but let's not give up on that. I hope for a day, and I'm not, again, naive to the fact that kids are always going to come to a university and wish to experiment with drugs. That will exist long after I'm gone. But nonetheless, I don't think we give up on that. I actually hope there is a day when youth are more informed and more educated about the dangers of going down the pathways of using stimulants or relying on an Adderall to keep them up for a test or whatever that might be. But I also then hope that, again, that we have a policy in place where if that youth does choose to use and they made an informed, educated decision and we put all those things in place, well, maybe there is a way that they can see somebody at the university. I'm not, I'm open to those thoughts and those discussions. How that works, we probably have a lot more work to do.
There's possibility though. Like I think, we always think about legal regulation as like alcohol, tobacco, like where we had, for-profit commercial parties that were driven to induce demand and get people, even in the pharmaceutical way, right? Like where we have a prescription opioid problem. Like there was a real emphasis on building demand and building a huge market. This would only work if you took a demand reduction framework. So I think it would have to be something that's essentially like state controlled and is about, okay, we recognize the reality that some people use drugs and that's part of adolescence for many people and it has been for centuries and it's unlikely to change. How can we provide that opportunity in a way that is not designed to promote drug use, that is not designed to promote more potent products like we see on the illegal market, that's not designed to encourage people to transition to more dangerous substances, but still provides that opportunity to alter consciousness. And I don't think we've had that conversation of what that looks like, but I don't think it's out of the realm of reality. And I think, to plug Donald, it's a different university, but next month in May in Vancouver, Donald's organization is bringing together international experts on drug policy reform to start to have those conversations of what different models would look like to solve the opioid crisis.
I want to turn the page. This is an excellent question submitted by a member of our audience, and I want to put this to Chanel. Many of the professionals and workers on the front lines are experiencing massive amounts of loss and vicariously experiencing trauma by way of the people that they care for. This is not being recognized. There's a lack of education, there's a lack of workplace wellness initiatives, and many of these people are at risk of their own psychological trauma and subsequently leaving what they're doing. How do we address this?
Wow, that's a really good question. I think for myself, I recently have had to come to terms and acknowledge my own state of mental health, just in regards to the amount of grief and loss that we have not only in the inner city, but across the country, and in knowing groups like Mom Stop the Harms and other substance use organizations across the country. It's really quite terrifying because, as professionals, I think they receive, training. I know some of the nurses on their team, I've been called before an empathetic sponge. Some of the nurses and the professionals on our team have had some type of training when it comes to, I don't know, I wouldn't say deflecting, but being able to not absorb and take home so much, but I don't think and necessarily that's true. So coming into my role as somebody with lived experience and obviously being a person who uses drugs and having experienced my own trauma that I carry with me, having vicarious trauma and through, the thousands of people that I've come into contact with, and like we've seen, each person has a story. I've heard some very horrific stories from people, but at the same time, I've been able to be witness to the absolute resilience of people, and I thank the giants of the shoulders I've been able to stand on for the support and how to navigate that. But I think right now, we've heard, down in Calgary, a firefighter saying, We're fed up and we've had enough and we're overwhelmed. I think if you turn around and you look, if the professionals are saying like, hey, look, like we've had enough, imagine the family members of all of the faces of the young people that we've seen on the screen. Do you think that they have not had enough? I think in reality, we need more activists. We need this room full of people to turn around and like Lorna and Angela from Mom Stop the Harm. We need you guys to turn around and be activists in the community too when it comes to doing things like stopping the stigma and discrimination, to have conversations about substance use through a different lens with your family and friends in regards to the trauma that everyone has experienced. I don't know. How do we get over? We don't. You keep fighting and you hope and pray that one day the people who lie in power and set up in the ivory towers and make the policy decisions and you hope they listen and nothing is falling on deaf ears, and why aren't these brilliant minds being enacted upon? Where are these great ideas going to be shuffled in a file folder somewhere and sit on somebody's desk? Like, these are the actions that we've heard up here tonight that we need so desperately to be implemented now. So.
Doctor, how do we talk to children and adolescents about opioids?
I think very openly. I think you need to start those conversations early and have an open conversation about what drug use is and where people can get help. And like I said earlier, I think those situations need to be role played. That's really the only evidence we have in terms of changing behavior. It's not scaring kids, telling them don't ever do drugs. It's showing people how to get out of difficult situations and being there for them if they ever do call you when they're in a difficult situation, and not judging them, and lots of practice.
Does the panel concur?
I think just from a prevention perspective, one of the best analogies I ever heard was, when you talk about Nike Canada or Lay's potato chips or whatever, their messaging for advertising is always a long-term sustained message. And typically what we've done for prevention for drugs is, one of our police officers comes in once a year before grad and says, don't do drugs, and here's why, and then we walk out. And that's not the way to do this. I'm really advocating that it's got to be part of a curriculum program for youth right from a very young age all the way to they graduate, not just about drugs, but about making good informed decisions, about understanding the impacts of their decisions. And having that and I agree with the role playing, and it's a long-term they would advance with a youth as they go from K to grade 12. So that's something I'm advocating as far as, us educating is long-term and sustained and not just that once-a-year message.
The most effective prevention is not talking about drugs. Like, the most effective prevention has nothing to do with drugs. And so I agree that education is important, and always that question comes up of how do you talk to your kids, and people want to know that because their kids have questions and they need answers. But what's effective for preventing substance use is investing in the social determinants of health. So starting early. We know the two big determinants of why people may end up using drugs are feeling alienated from their peer group, or being connected to a peer group where there's access to drugs, working towards building a sense of social inclusion is really important for young people, and that has nothing to do with drugs. That has everything to do with in promoting healthy school environments, to checking in with mental health, to ensuring that people have strong systems of social support. The second determinant we know is really important is parental-child attachment. And so at a population level, there's evidence that suggests when parents are under stress or they're potentially struggling, that puts kids at risk as well. So how do we strengthen that? It's not educating them that drugs are dangerous. It's saying, well, we know you're struggling for X, Y, and Z. What are the supports we can put in place to help you? So again, reducing child poverty, ensuring that families have access to recreational activities, different opportunities that their kids can engage in. Those are the investments that really will pay money. We spend so much money on flashy ad campaigns that don't change anything, but they make us feel good. And I would really like to see all that money reoriented and much more into a system of prevention that actually works. And we won't only reap the benefits in terms of reduced substance use, but we'll reap the benefits in terms of reduce, risky adolescent sexual activity, STIs. We'll reap the benefits in terms of reductions in violence and mental health problems. So why wouldn't we make those investments? And there's actually a case study in Iceland that showed where they did take a systematic country-level approach to investing in communities, to building up school communities. So children had good recreation opportunities, families felt connected to one another, could reach out to each other for support, and they saw significant reductions in alcohol and cannabis and hash use for those efforts. So it can be done, we just need the will to do it.
In a way, our current approach of sort of seeing drugs as a problem and is a real distraction from doing all of that. So we're 75% of our national budget goes towards enforcement on the drug side of things, and we're chasing drugs all the time. Drugs are the problem. Well, no, this is the problem. We're not doing what Elaine is just talking about. But we keep doing this over and over and over again and neglecting the real prevention stuff. And
to put it in perspective, because we always say, oh, well, we don't have the money for that stuff. Well, the United States of America has put in trillions of dollars into drug law enforcement, just drug law enforcement, trillions. Could you imagine if that money was reoriented into building communities, supporting people, getting them access to healthcare? They would go far, far further in terms of reducing access to substances and reducing drug use if we invested in those determinants.
Here's where the cynical talk show host in me comes out, though.
It always happens.
Yeah, because, we take a look at what governments spend on and why they spend on what they spend on. And it's a lot of times based on what they understand with regards to the public's political appetite, what plays well, what can be thrown around as a political football to a certain degree. Doctor, you have been on my program many times, and you're well aware of many of what a tragic, typical public response can be to conversations about opioid overdoses, fentanyl overdoses, and people oftentimes will refer to the phrase of it's a certain thing is not someone's fault, other things are someone's fault. If 2 people a day in Alberta were dying from something that had nothing to do with any personal choice, so to speak, the political will to address it may be much stronger. Do you believe that governments are not spending significantly on issues like the ones or initiatives like the ones we're talking about because they don't see, the political reward at the end of the journey?
I think the political, they get a quicker political reward by saying things that actually don't work. We're going to be tough on drugs, we're going to have mandatory minimum sentences, we're going to run all the dealers out of town, and stuff we've heard over and over and over again for over 100 years. We've met the enemy, and the enemy is us, right? We keep electing people who do not put the priority on social development, as Elaine was talking, and from all parties. I mean, all parties are guilty of that, the election cycle. So it really, those are the 2 things. There's a refusal to admit our public policy, our drug policy is broken and needs to be changed, and not investing in what really are the social determinants of health, the real prevention stuff.
But Ryan, I guess the only thing I'd want to say is I do not want to get to a point where we don't think that enforcement is an appropriate strategy. For those that are importing, for those that are producing, for those that are trafficking, we need to have a strong enforcement. But the problem is, to your point, Elaine, is we've put a disproportionate amount of funding into one of the pillars. And what we need to do is look at a unified strategy that looks at all 4 pillars. And I think that's probably more what we're talking about. I don't want you to leave here thinking that I'm not believing that enforcement is an appropriate strategy, because it really is. Is it going to solve the problem? Absolutely not. I wish I could tell you it will, but it won't. But what I am saying is, look at the investment into the 4 pillars. Look at everything is going to make a difference in its own way. But please don't leave here thinking that is not an appropriate role.
But Chief, what about those of us that have, to a certain degree, been led to believe that it's almost unenforceable? I mean, I'm sort of spinning a bit of a yarn here. Don't take this as science, but basically, wouldn't you have, from a punch power standpoint, the equivalence of a brick of fentanyl the size of a pencil case? You'd be talking about a pallet of anything else? I mean, when you look at Canada Border Services, the RCMP, police forces across the country, how much more of a challenge is enforcement in the context of this conversation versus anything else we've seen?
Oh, fentanyl. I wish I could tell you that we could slow down fentanyl. We cannot. It's coming through the mail in unprecedented amounts, and it's incredibly difficult for us to control. So as I said before, we are not going to control supply. That being said, we cannot let the transnational organized crime groups go unchecked. We need to stay on top of them. We need to continue to work with places like China, which the U.S. has just done to help to regulate fentanyl and precursors from coming into Canada. But I'm not naive. I am not going to well, I remember as a drug cop standing in front of a seizure or being around a big seizure, and we're all high-fiving and we're very proud and good work, and I don't want to diminish that, but all we did was for a short period of time increase the price of the drugs on the street. For a very, very short time. People had no problem getting the drugs again the very next day. So I think most of us cops are not unrealistic. We get that. But we also know that we have to, and it's a criminal justice system. We're seeing in British Columbia, for example, where fentanyl traffickers are getting significant sentences for change. So the word is out there. But I do believe that the money needs to be distributed in a way that is looking at all the tools and not just working in silos.
Catherine?
I think the way to do this really lies with all of you. So it is so fantastic to see so many here tonight. It is you that can pressure the political system to make the right decision. It's you here tonight, it's you talking to your family, it's you talking to your friends. It's having this conversation where it's okay to talk about drugs. And people seek treatment, they feel like they can talk to me about their drug use the same way they were talked to me about their diabetes. That is how we're going to make change. It is with you. We are fighting as hard as we possibly can up here. The change lies with you.
Beautifully said, and it feels like a perfect point to wrap this up. You built us to this crescendo. But I just can't. Because there's another question on here that begs to be asked, and perhaps I should have asked it at the outset, but whether we're talking about surgical wait times or physician recruitment or access to services, it seems like here in the province of Alberta we're having parallel but very separate conversations based on rural and urban realities. Is that a factor in this conversation tonight?
100%. You can't access the same treatment in a rural setting that you can access in downtown Edmonton. That's a major problem.
What do we know about drug use in rural communities, poison drugs in rural communities?
Yeah, so I think it's important to note that drug use occurs across the socioeconomic spectrum, but we do know that certain demographics are affected, and Catherine raised two, like males that are in their 30s, but we also know that Indigenous people are disproportionately impacted, and particularly on reserves like in southern Alberta, we've seen carnage from that, and there is a significant lack of the social determinants of health in that area that are exacerbating that crisis. But if you look at the death rates in terms of rural urban, we do know that over 80% of the deaths are concentrated in the municipal areas of the province, and that's in part artifact of population. But Dr. Dong's 100% right. Like if you think the services are difficult to navigate in the cities, they're even harder to navigate in the rural areas. Although there has been some advances made in the last few months actually to try and expand access to treatment to rural populations, it's not enough.
Okay. Whether it's going to be a comment on additional gaps in service provision that maybe haven't been touched on yet, or maybe it's a charge to our audience, I want to give each of you the opportunity to offer a brief closing remark. Give us something to chew on, something to walk with for the rest of this week, and we'll just make our way down from Dr. Hishka to Dr. Dong.
Sure. So I just wanted to acknowledge Mom Stop the Harm and Chanel and all the amazing work that happens with AWARE and Kaput. Like, we won't change the conversation as a society until without hearing from stories of people that are impacted. And there's such bravery and courage in all these groups and people making themselves vulnerable in a very public way and sharing a very private story in a very public fashion because they want to prevent what's happened to them from happening to other people. And so I think we should actually give a round of applause to all the people that are willing to speak publicly because it is so...
I guess I'll say two things. And first, through this crisis, and in one in the 90s, people with lived experience started organizing because they weren't getting the services, and the services they were getting were not adequate or tailored to what they needed. So the importance of organizations like AWARE, the bar has been raised for any organization wanting to work in this issue, for health authorities, for provincial governments who are developing policy frameworks. If they don't have a good contingent of people with lived experience involved from the get-go in the process, they're going to miss it. They're going to miss the mark. So many of the good ideas are coming from people who actually work, have been there, can tell you that won't work, Donald. You're an idiot. And I guess the second thing, which you won't be surprised, I'll say, you know, you can't walk out of this room and if you're not willing to do your own homework, look at the evidence of how catastrophically failed our policies are, and begin to support efforts to change them in small, medium, and large ways, we will be here 10 years from now talking about some other toxic substance in the water or the well or the drug market.
Yeah, so I guess we live in a world where injustice, inequality right now reign. For me, I see activism as the solution. For me, I couldn't continue to do my job effectively without having an outlet for advocacy. Being an outreach worker, I've had to experience that, yeah, what we were just talking about here, the lack of resources, even those from the country. I can tell you, I can attest to you, being an outreach worker for the Needle Exchange program here in the city, that we have folks that drive from another province to come to Edmonton to access services. So if that's not telling you something very dire, I don't know what else to share. Activism for me is the solution. So when social change is necessary, it's oftentimes blocked by suffering and grows, but so does the social pressure to begin to change things. And for me, activism is crucial as a society, and I would encourage you all to leave here today and have those conversations with your friends and family, and to encourage people who might still view substance use through a criminal or a moral lens, or as a moral failing, that it is in fact a health issue. You've heard here today from 2 doctors and 2 professors and a chief of police that indeed this is not a moral failing, but this is a health issue that needs to be acted upon, and should have been acted upon 3 years ago when we declared an emergency in BC, because it's spread across our country. And yeah, time to remember and a time to act, and the time to act has long passed. I would encourage you all to join us April 13th. Sorry, a little selfless plug here. We're partnering, AWARE, Canadian Association of People Who Use Drugs, and Mom Stop the Harm are partnering to host a free screening of the opiate documentary Painkiller Inside the Opiate Crisis on April 13th at 3:30 at the Metro Cinema. Admission is free, and you will hear from a panel of folks from Kaput, AWARE, and Mom Stop the Harm. And also a medical professional. I would also invite you to join us, without touching on too many political subjects, but on April 16th, we will be outside of the federal building and delivering provincial and federal demands to our governments across the country. We have a National Day of Action happening with Canadian Association of People Who Use Drugs and substance user organizations across the country, in provinces right from Vancouver Island to Halifax. So on that day, on National Day of Action, here at Edmonton, our event will be noon at the federal building, and we encourage anyone to come who has themselves been affected by this crisis, or has a friend or a loved one. So please come and join us.
So almost 3 years ago, we declared a public health emergency in British Columbia. We stopped working in silos. We've worked closer together with everybody in British Columbia. I have such a good relationship with health and social services and city and leaders in the province. And yet, last year, we had over 1,500 people die of an overdose, despite all that effort and money that we did. So my message would be is we have to think differently. Let's challenge ourselves. Let's push ourselves. Let's think differently. I'm proud to say that I started on the Drug Advisory Committee for the Canadian Association of Chiefs 5 years ago. I threw out the idea that marijuana one day might be legalized, and I was kind of that crazy guy from the West Coast that but now I'm saying that, now's the time to think differently when it comes to all drugs. And 5 years ago, they were hesitant on marijuana. Well, now the chiefs are listening, and I'm very proud of our police organizations across Canada because you have a group of people who care desperately about the safety of people in our communities. I'm not saying we have all the answers, but what I'm saying is law enforcement does get that we need to look at different ways and we need to be proactive. And I hope that you got some of that message today, that we are prepared to think differently and try to find new solutions to this very complex problem.
I'd like to leave you just with 3 points tonight. Stigma and discrimination are killing people. We need to fix that, and that is everybody's responsibility to do that in this room. I hope you have a better understanding of how drug use works. I think healthcare providers of every discipline need to know how to talk to people about drugs in a patient-centered way, and they need to know what to do with those answers. We need to make sure that we don't miss any single opportunity where we can intervene and start to change that conversation and engage people into care. So those are the things I'd like you to think about.
Please join me in thanking tonight's panelists. If our panelists would take your seats, please. I'd like to personally thank Chancellor Stollery, of course, the University of Alberta, the Senate, the School of Public Health for providing this incredible opportunity. And I'd like to welcome to the front of the room the Dean at the University of Alberta's School of Public Health, Shanti Johnson.
Good evening. Let me add my thanks to the fantastic panel. They talked a lot about education, enforcement, along the whole spectrum. Thank you for what you do in terms of your research and work. I want to thank our moderator, Ryan Jesperson, who skillfully guided the conversation that took us to the breadth and depth of the conversation that was needed. Join me in thanking. Thank you to the audience in the room and at the distance for your engagement. Many of you provided some questions ahead during your registration that was built into the conversation, so thank you for your engagement and involvement. As we heard this evening, the opioid crisis is a complicated public health issue that touches the lives of people in all walks of life. We heard some statistics in terms of it being very common, the death rates, and so on. It is also very consequential and devastating to people's lives, not only individuals, as families and communities as well. And it is also complex, as we heard, in terms of the predisposing factors, but the solutions are complex and multi-layered. The School of Public Health is playing a key role in addressing the issue, as are other faculties on campus. The research posters that you viewed outside the lecture theater represent the work done by our faculty member, Dr. Cam Wilde, and his research group. Dr. Cam Wilde is here with us. The aim of this group is to support the creation of more effective and personal intervention programs and services. In addition, we are working together with others in many sectors, such as you saw in the panel today: law enforcement, healthcare, government, academia, and non-governmental agencies. We are honored to work together with Moms Stop the Harm, StreetWorks Harm Reduction, Canadian Drug Policy Coalition, Inner City Health and Wellness Programs, and many others. Only when all of us work together will we get at the underlying issues and take actions that prevent further harm. It is a great honor for the School of Public Health to be an academic partner of the Office of the Chancellor and Senate at this evening's event. Thank you, Chancellor Stollery. We are also pleased to collaborate with our campus colleagues, the Faculty of Medicine and Dentistry, Alumni Association, and University Relations. Thank you. I also want to acknowledge the generous support of our event sponsor, our Royal Alexandra Hospital Foundation. Thank you. Thank you for the foundation and its donors for your ongoing support, for the work that's done at the University of Alberta. Your generous contributions are fueling new ideas and research discoveries. You are making a mark on public health and healthcare in Alberta. As we've heard this evening, the consequences of opioid crisis are truly devastating. We've seen the images of loved ones lost and heard from the love letters of parents. There has been too much tragedy and too much pain already. But as we've also heard from our panelists, there is a way forward. As Dr. Catherine Dong called, each of us have a role to play. It is critical that our scholars continue to do research that provides strong evidence to inform policy decisions and programs that reduce harm and support people. We heard that we know already a lot of evidence that can be implemented, and research is needed to fill the gaps that exist. It is critical for each of us to play a part in terms of understanding, continue to do research. It is critical that law enforcement, healthcare, government, academia, and non-governmental agencies are working together to understand and address the underlying issues. It is critical that each of us continue to play a part. I applaud all of you for being here tonight and for your thoughtful questions many of you sent to us in advance to help guide the conversation. I urge you to continue asking questions and learning about this issue, which is costly, consequential, and complex. Share what you have heard here this evening with your friends, neighbors, and colleagues, and be the change that we want to see in our community. Let us work together to find ways forward, to reduce stigma, and to identify solutions that will reduce harm and protect health of our community. Thank you, and good evening.